everybody to Kittitas County Public Hospital District Number 1 Board of Commissioners regular meeting. I'd like to call the meeting to order. Mandy Weed, are you there?
Yep, I'm here.
Can you do a roll call for us?
Bob Davis,
Here.
Erica Libanow,
Here.
Matt Altman,
Here.
John Ward,
Here.
Terry Clark,
Here.
Julie Peterson,
Here.
Scott Olander,
Here.
Dr. Martin,
Here.
Vicky Machero, Rhonda Holden, looks like Rhonda's muted.
I'm here.
There you go. Mandy Olson,
I'm here.
Carrie Barr,
Here.
Amanda Scott,
Here.
Michelle Whirl,
Here.
Dr. O'Brien,
Here.
Jason Adler, Lisa Potter,
I'm here.
and then anyone else that's on the line.
Bill Hinkle's here.
Thank you.
Yeah, welcome everybody, and welcome Bill. Thanks for being here. Our first item on the agenda is the approval of the agenda. And if there are any items that need to be pulled from the agenda.
I will move to approve the agenda.
We have a motion by Erica,
Second.
second by Matt. All in favor, say aye.
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 We have the consent agenda. Can we get a motion to accept the consent agenda?
So moved.
And a second?
I'll second.
Second. Any discussion? All in favor, say aye.
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 No opposed? So public comment. I think Bill's gonna say a comment, Mr. Hinkle. So Bill, we usually keep them to around 3 minutes or so, and then most of the time we don't. As board members, we don't comment a lot, but I'd welcome you any kind of comments or anything you wish to share with us.
Okay, I'll keep it under 3 minutes. Thank you, Mr. President, ladies and gentlemen of the board and staff. For the record, my name's Bill Hinkle. Since there's a couple of board members here that don't know who I am, I give you a little background on myself. I worked in Seattle area as a paramedic for 17 years before being elected to county commissioner, where I served about 4 of those years in the Board of Health. I was then elected to the House of Representatives, where I served for 10 years. I served 12 years on the Yakima Regional Board, Yakima Regional Hospital Board of Directors. Got out the year before they went bankrupt, by the way. I saw the writing on the wall there. I served 4 years on the Health Exchange Board. Currently, I serve as Administrative Law Judge with the Environmental Land Use Hearings Office and Growth Management Hearings Board. So I've been in healthcare about my whole life. And first of all, I want to thank all of you for the great care both myself and my family have received in your facility over the years. I have no complaints there. Your staff are professional, they're competent, they're compassionate caregivers. I know many of you personally, and I believe that everybody's trying to do the right thing. Some of you are actually friends. I spent a lot of time with you talking about deep stuff. So I appreciate your service and thank you for it. I want to tell you a little experience I've had though in the last few months since we started this COVID thing, and I understand why, but I went in with to the hospital with extreme belly pain. My wife was asked at midnight to wait out in the car She didn't know if I was going to live or die. Thank God I lived. Had another similar situation. My aunt, she's 77 years old and kind of frail and gets confused. And I'm the closest relative to her. I was asked to stay out of the room also and leave the hospital. Just this last weekend, my mom went in and couldn't bear any weight on her hip, and she gets confused and very nervous, and I wasn't allowed to stay in there. And frankly, I know if I try to make a strong case, and I called Julie, I was pretty upset, and Julie said, be nice to the nurse and see what you can do. Well, the best I could get was they'll call me if there's any decisions to be made. But I think this is, in all my years in healthcare, this is kind of the most inhumane thing I've seen in a long time, and it's not this way around the state. In Swedish in particular, they allow one person in the ER, especially with frail older people. That's just happened to a friend of mine. Now they designate that person as the closest, member. I looked at the CDC guidelines very carefully. This idea that you don't let anybody in the hospital is just not there. It is, in certain cases, in particular when you have COVID positive people in the hospital and that kind of thing. But I think what I see from reading the recommendations is you're going a little beyond what the CDC is saying you have to do. And there is some options there for you to actually let people in that are critical and essential for giving care here. In my whole life, I've never seen anything like this, where suddenly clergy are not an essential part of the healthcare team. When people are passing from death to life, the most important time of their life here on earth, we're leaving it to the discretion of the staff without, I think, really adequate policy or science to prove that that's absolutely necessary. Since when, is clergy not a critical member of the staff, as they've been for years? And I also believe it's probably the most inhumane thing I've ever seen in the history of public policy, to keep at least one loved one away in times when people need help, both being an advocate and helping them decipher what's being told them by the medical professionals. There's some options here that you can take that I would beg you to do, just, to show some compassion. As I told Julie, you have to be advocates for the people that come into your hospital and not just be bureaucrats worried about the bottom line and or whatever perceived liability there may be. This is not the first time we've experienced death. It's not the first time we experienced communicable diseases. We can handle this. We've done it before, and we can do it safely, and there are measures that can be taken. So I'd encourage you to do that. And with that, I'd be happy to respond to any questions.
Thank you, Bill. Yeah, I appreciate that. I mean, I think healthcare is struggling with that issue in a big way. So it's just kind of knowing what the right thing to do, and it's trying to take the safe approaches. But I definitely see your point.
Well, we're phase 3 over here, and King County's not even in phase 2 yet. And in Swedish, I stayed out from my wife when she went to get her CT, and she's very claustrophobic. Of course, I wouldn't be able to go in there anyway, but I could at least calm her down before she got in the place. And they told her that, I could have come in. They just don't let a lot of visitors in if it starts getting crowded. So this idea that, I had to leave the hospital to use the restroom while I'm waiting for my mother in the ER. I had to drive away. They won't even let me in to use the restroom. I just think this is kind of inhumane, you guys, and it's kind of beyond the pale. So please consider this. There's really, you have some options, and remember, this is tax-funded, taxpayer supported. So you think you have some accountability to the patients and the taxpayers too. Please. Thank you.
Thank you.
Okay, bye-bye.
I appreciate the comment.
All right.
Reports and dashboards.
Bob?
I do-
This is Mandy. Sorry to interrupt just real quick.
Yeah.
I put the meeting number on the agenda incorrectly, and I just got an email. There's another employee that's trying to call in, so she may be calling in a moment. I just sent it to her. So we may have another public comment period. So I apologize for that.
Okay. Yeah, There was an error on where the meeting number was off. So should we wait for that person a few minutes? Is there someone else that just came on?
Stacy Olea just came on. I believe Joan Bennett is trying to dial in.
Okay. Does the board want to go through quality and come back to another public comment?
That'd be fine with me, Bob. Yeah, that's
Okay.
fine. Whatever you think is best, Bob.
Yeah, I
let's-
think that's good, Bob. That's good.
Okay, so let's go on to quality with Mandy Olson, and then we'll come back to public comment.
So I have my report in the packet, but also we did have QI Council, and so I don't know if Matt or Terry have any comments about our most recent QI Council.
Terry, you have anything to say?
Well, it was an awesome report, as always, that Mandy does. And it does appear that we are doing very well with our quality assurance. And I think I'll just turn it over to Mandy and let her tell us how awesome we're doing.
And I am happy to share my screen or run over my report and the dashboards if that would be helpful. I know we talked about at QI Council, it was helpful to have the dashboard up when I was talking about things. So I'm happy to do that if that'd be helpful.
Yeah, I mean, you guys could all see the QI Council minutes. We had two presentations, one from Kathy Murray on a new billing process for home health. And then we had Carrie Barr talking about the Medicare annual wellness and chronic care management improvement projects. So those were pretty good. I think if you had questions about that, I would ask, I mean, Mandy could talk about the billing change if you'd like, and then Carrie Barr obviously could address the chronic care management thing. Do you guys have any questions about any of that stuff? Those two things in particular? I do not.
Okay.
Then I guess the only other thing to mention is that we, Terry Clark and I recently delivered the Safe Catch Awards in person. We had a lot of, a whole list of people were nominated this quarter, which was really nice. I guess they've started advertising Safe Catch nominations more often. So we're getting a lot more of those, and it's really nice for the QI Council to see all the great work that's being done. Terry and I, last Thursday, we went and delivered two of the Safe Catch Awards to people, sort of surprised them. That was really nice to do that in person. And then he and I went up to Cle Elum Family Medicine up there in Cle Elum today and delivered another Safe Catch Award. And I know Terry and I really enjoyed that. So that was great. We usually do it at the board meeting, you know, but since we're doing it by Zoom, we thought it would be more personal to do it that way.
And
Terry?
I'd like to just interject really fast, just from the staff's point of view. It's like winning the Publishing Clearinghouse sweepstakes. It's just been overwhelmingly, it's a shock to them, but it's this wonderful recognition. So thank you guys for spending that time and energy. That means a lot to them.
Oh, it was great. Yeah. Terry, anything to add?
Yeah, it was wonderful. It was really great to go in and see them in their work area, and all the other staff around there. They would gather up and they would all be cheering on the person with a safe catch. I enjoyed it. I think that's something Matt and I would probably even do once we get back to some part of normality, to be able to go out and see these people in their work area and congratulate them on doing their Safe Catch Award. we all do have to tell them that this is a good thing with all these people wandering up to them. And it's not something bad. It is a little, you can see a little, just a slight bit of terror in their eyes the second we come around the corner and they say that we're there to talk to them. But it all turns out well.
Yeah, the first
I
thing
will
have to
jump
say
in.
is this is a good thing. Yeah, I have to sell them.
We will be sharing videos of those at Monday's employee forum. So the rest of the staff will be able to see them as well. So, and if you're tuned in, so will you.
Great.
I like the idea of continuing it, an in-person surprise presentation even after it's not necessary to do so. That's a really good idea.
Yeah, I think it's a blast. So I think that's, with the exception of the dashboards and things, that's mostly what we did at QI Council. But we can go over the dashboards now. Any other questions before Mandy talks about her report and goes over the dashboards?
Well, I have a quick question for something that's in Mandy's report. Is this a good time?
Yeah, sure.
So sorry, my iPad is giving me a ton of notifications all of a sudden. On the bottom of the SARS, the COVID paragraph at the top, it says, to date, we have 915 employee contacts through COVID positive case reviews. Does that mean that's a contact tracing, that identified exposure, potential exposure there, and we followed 915 of those to make sure that all the loose ends are tied up?
Yes, that's well said, because it's not 900 individual employees, because some people have had multiple contacts with positive patients. So every time we get a positive result from testing at KVH, we look at that patient's chart and see all the potential interactions they had with staff, and we contact that staff. In some cases, it's a phone call because it's not clear if they knew that they should be in precautions or not, and so we want to ensure that the employee was protected. And in other cases, like when they're doing testing at the COVID clinic, they're anticipating that every patient that comes in the door there is positive, and so we are assuming they're wearing appropriate PPE, and so it's just a notification email, but then that they can contact us if they have further questions. So yeah, we have a log where each of these contacts is listed. I think we're up to 993 or something yesterday.
This is an average of many, many cases per day to follow up on. This is a lot of work. This is impressive.
It really depends on how our county's doing. So right now, we had no positives today, so that was no follow-up. I mean, we have an inpatient that we looked into, but yeah, so it really depends on how our county is doing.
Thank you.
Yeah.
Any other questions for Mandy?
No.
Thank you, Mandy. So let's go back to public comment. Do we have online a public member that wants to say comment?
Hello, can you hear me?
Yes, we can. Who is it?
This is Joan Bennett. Am I commenting on the COVID report?
No, we went through public comment and we were notified that the number was wrong. So we're coming back to just public comment and announcements. So if you have a comment, you have 3 minutes to make your comment, and the board usually doesn't comment on public comment, but we'd love to hear any thoughts that you had.
Okay, I have a comment about the Roth 457B. I'm really happy that that's been set up, and thank you very much for all the work that went into setting that up. However, we are not able to do an in-plan conversion from the traditional to the Roth at this time because of some restrictions on our policy, and I was wondering if somebody could look into that. I have been working with Chad Amos, and he seems to think that there's another person besides Marlo and Dan that needs to change that policy. My other comment is that I'm wondering about why we should be remodeling the lab. I do work in the lab, and I understand that we're now going to be moved upstairs and then downstairs again, and I can't understand why the lab remodel has become so complicated. Originally, we thought it was just going to be opening up space next door so that we could potentially shift some equipment or supplies over there. But it's become quite complicated, and my understanding is quite expensive as well. So I was wondering if we could reconsider the lab remodel plan.
Great. Thank you, Joan.
Thank you.
I appreciate it. Appreciate your time.
Thank you.
We will now move into the CEO report.
Okay.
Julie?
Yeah, I'll let Mandy Weed jump in here real quickly. I jumped out for a minute to talk with her. Because the wrong phone-in number was published, she will be posting a note on our website. We'll make sure we're linked to this recording, but see what we can do to make sure that that gets fixed. So anybody who wanted to either see this or participate, we'll make our apologies and make sure they have access to the video. So anything else, Mandy?
Nope, I think that covers it.
Okay. Yeah, I'm happy to answer questions about my report, but I did have a couple of things to add. We're really excited to announce that Hospital District 2 had a successful bid on their ambulance garage. We have a contract with T.W. Clark that T.W. Clark has signed, and on Monday evening, we hope to have that fully executed by Hospital District 2's board. So anything to add to that, Rhonda?
Nope, we're very excited.
We are, and Randy Kaiser will be functioning as the project manager there, so we have a contract in place to loan him to that project for the duration. So exciting steps forward. I did want to mention to the board, and I'm not asking for action at this point, but we've been approached by Hospice Friends, and as you recall, when we relocated OT and speech, Hospice Friends moved into that building. And just to kind of remind you what the relationship, they are a completely independent organization, but they support our hospice services with volunteers. They have DME. So they are a separate organization, but they're very much part of the hospice delivery system for KVH Hospice. They moved into that space, and I think it's been a successful transition for them. They reached out to see if we would be at all interested in selling that building to them. So we're leasing it to them right now because they're a not-for-profit who supports our mission at significantly less than market. They raise funds in the community, but most of those funds they try to turn into DME and supplies for folks on hospice. We purchased that property back in 1996 for $220,000. So my first question, I guess, to Hospice Friends is why do they want to purchase it when we're willing to lease it to them for very little money? But once I've had that conversation, I'll come back to the board. The process for selling real property as a hospital district is to surplus that property and then establish a fair market value for it and sell it to a willing purchaser. So any questions about that?
Julie, what is the lease term, the lease length that we currently have established with them?
I believe it's a month to month.
Okay,
and that's one of the things that we talked about, and Rhonda is on the board of Hospice Friends, is, are they concerned that, I think they've had some less than successful lease relationships in the past. So if a longer term lease, we have no plans for that building that I'm aware of. I don't know what we would put there. And again, Hospice Friends is a very valuable partner. So if they would want a longer lease or different terms for exiting that lease, I just need to reach out and find out why they're thinking about purchasing it. They don't have unlimited cash, so it's just kind of curious.
Great. Any other questions for Julie?
I do have a couple more things I'd like to.
Sorry, Julie.
No, that's okay. Yes, yesterday we had or actually all week we've been doing our employee appreciation in lieu of the barbecue that we typically do. And so we did one at the MAC. We went up to Radio Hill, and yesterday we did the hospital. It really was just a lot of fun. I think people missed the barbecue. That kind of broke everybody's heart that we didn't get to do that. But Mandy Weed and I did go into Michelle Worrell's office, and we stole all the remaining Be Kind face masks and went around the hospital distributing them. So people just really seemed to enjoy it. And food services, as always, did an amazing job. So I think Michelle mentioned that Monday at noon, we're going to have the next electronic employee forum. So we'll be rolling out the films on the Safe Catch Award, and we have a number of other things that we'll be talking about at that time. Some of our focus is on supporting the folks that are struggling with how their kids are going to get back to school and what that means to their jobs here and how we can support them. But noon on Monday, we'll be doing the next version of that show. The foundation is, of course, not holding their big fundraisers this year, and with the rodeo not occurring, that's when they generally do their Tough Enough to Wear Pink fundraisers. So I just wanted to point you all to their website. Tough Enough to Wear Pink is virtual and online this year, but they have some of the great t-shirts and products that they usually are out in the hallways selling.
Can I jump in on that one?
Yeah, absolutely.
They will also be doing regularly during the month of October. GUARD has been a great partner in raising funds for Tough Enough to Wear Pink. And they would do an event with the live music on the third Thursday in October where the proceeds go to Tough Enough. This year, they're going to do 2 similar events, practicing all of the standard social distancing requirements that are in place at the time. The first one will be Labor Day weekend, and I don't have the exact date, but you can watch. We'll be sending it out as we get the October date, but that's another opportunity to help support those efforts.
And the last thing I wanted to mention, and if Amanda Scott wants to jump in, she's welcome to, but you know, we jumped into this remote work idea with everyone else when the COVID thing started, and now we're kind of backing up and trying to formalize our policies and our process for making people or having people work from home or work remotely. So the first step that we're going to take in that is to designate each one of our job descriptions as either remote eligible or not. So everyone we're going through those job descriptions and saying, you know, obviously a med-surg nurse is going to have a very difficult time working from home, but looking at each position in the organization and saying it's either partially or fully designated as remote eligible. And then of course there's rules around how that would be implemented. Anything else, Amanda?
No, I would just add that that we also would look at any individual accommodations, of course, as usual, in addition to the jobs, and kind of scaling what percentage of remote work. So if it's a primary remote work location or an occasional, and working with the managers on that. But well said, Julie, thank you.
And that's it. Happy to answer any questions.
Julie, I wanted to say I appreciate the detail on your report on the COVID response. That was good. And I also really liked hearing how You guys responded to the public concern that was raised at the last meeting. This has been something that, I don't know, sometimes we hear these public concerns at meetings and we're not sure who responds to them. I know that someone always responds to them and tries to address them, but it's nice to get that kind of feedback. And then if we could sort of keep that up, maybe since we had 2 concerns raised today, it doesn't have to be in your report necessarily. It could just be verbally or something like that, but just to hear how we've responded to those, I'd appreciate that.
Happy to do that.
Thank you.
Any other questions for Julie? Medical staff, Dr. O'Brien.
Yes, can you hear me? Okay.
Can.
Okay, yeah, we have just 5 this month. Welcome change from last month. Carrie Weiss is going to applying for initial privileges appointment as an ED part-time per diem provider. She worked here in the past and was very well appreciated and liked at that time. Larry Berger is up for reappointment, and Don Orminsky, podiatrist, doesn't do much up here, but he's reapplying for his privileges for podiatry. Laurel Gorham, nurse practitioner, geriatric, no, pediatric.
Wrong end of the lifespan.
Yeah, pediatric. Is just wanting to add the privilege of taking care of jaundice babies, which when we discussed it, we felt that's really a core privilege for a pediatric nurse practitioner or pediatrician, you know. But anyway, there's no problem whatsoever granting her that additional privilege of caring for jaundice babies. It's a fairly straightforward thing to do. And lastly, Julia Reel had one minor little thing happen last year that was quickly settled. Not her fault. Anyway, she's up for reappointment. And we recommend, the NEC has reviewed these in detail and recommend that you approve these 5 applications for initial appointment and reappointments.
So I would move to approve.
A motion by Jim,
I'm
a
sorry.
second by Terry to approve credentials files that Dr. O'Brien talked about. All in favor?
Aye.
Aye.
Any opposed? Great. Thank you, Dr. O'Brien.
Thank you. Yep.
Dr. Martin.
Thank you. You have my report in front of you. And really it's the usual array of activities. What I really want to focus on is the work that the county incident management team and our partners in the community did when we had multiple or positive, COVID positive residents in different facilities. The county set up an alternative care facility that frankly wouldn't have, well, back up a step. The idea for partnering with them started with Julie. The heavy lift was done by the county and leaned heavily on Rhonda. She pulled shifts working the floor. She was making sure that we were staffed, or excuse me, that we were stocked. Vicki took care of staffing. It was just a really remarkable effort. If you look nationally, you would expect that in an outbreak like that, you would have at least 35% mortality. We came out at Prestige, they had a number that was significantly lower than that. It could have been very, very much worse. And it was a novel situation, and standing up an alternative care facility is something that the disaster management folks drill. Usually the assumption is it's something like Mount Rainier just blew up and we need to set up a place to triage the injured. And the idea is that there is an affected area where you set up the care facility, and an unaffected area where you draw staff from. This was different. The affected area, well, where we set it up was private property. It wasn't the fairgrounds or the university. So we had to, in real time, negotiate an agreement with the landowner to be able to use the facility that way, mobilize it, and run it. And it was a remarkable effort that made a difference and saved lives. And other than that, we haven't been doing a darn thing for the last 5 weeks. The other thing I want to call out is Kyle West is moving to a new position in the organization. I've been talking a lot about trying to standardize our teaching programs here. There are times where we have more preceptors than students, and times where we have a logjam with trying to get students in. And we recently had the experience of having 2 students show up to work with the same provider for the same month. So I've been trying to get some structure around that. Kyle is going to be transitioning to HR and working as our volunteer and student services coordinator. And so that will move that work along, especially since right now he doesn't have to worry too much about volunteers. I want to thank him for the work he's done in that role in the last couple of years. And I'll take any questions you have.
I have a question about on your projects, urology. I just want some clarification. We're working with Yakima. Are they consulting for us, or are we partnering with them? What does it mean when they say we're working with them?
We've had conversations with them about doing more cases here. Currently, they see patients in town, but they do all of their surgical cases at Virginia Mason. One of the opportunities that presents itself to us with the closure of Astria is that suddenly operating room time in Yakima is at a premium. And so a lot of practices that may have found it more efficient to do their cases to our south are finding that they're having troubles getting OR time. And that presents an opportunity for us to provide better access for our residents and keep the care here.
Terrific, thank you. And I also just want to say, based on everything I heard, yourself and Vicki and Rhonda and what you guys did over at the ACF, I'm just really proud of and really impressed. So, know that, we've heard and we're aware, and just really honored to have people such as yourselves stepping forward and just handling that situation.
Thank you, it's a great team.
Yeah, for sure. Good job. Thanks, John. Any other questions for Dr. Martin? Thank you. Finance. Scott, are you there?
I am here. Well, I have the pleasure of bringing a very good financial report to the board. We had a positive revenue variance for the month of a significant positive revenue variance. We've been very conservative in how we have estimated our recovery rate with our contractual adjustments. We had some CARES money that we recognized in other operating revenue. We had a vendor that made a significant contribution that's reflected in other operating revenue, about $140K. Expenses were nearly all below budget. We were negative variance with supplies, but we have been intentional about acquiring additional PPE, additional biofire tests, additional lab tests. When they are available, we are purchasing them to make sure that we are well stocked. The supply chain, I think, continues to be somewhat unstable. So I wouldn't say that we're hoarding, but we're taking advantage of opportunities to have plenty of supplies available so that we don't put ourselves in a position that we don't have adequate for our staff and patients. So with overall expenses had a positive revenue or expense variance of 296,000. With all of this, with the additional revenue and positive variance with expenses, we ended up with a operating income of almost $1.1 million for the month. And year to date, we are at $1.5 million, and we're ahead of our year to date net operating income budget. I would make a comment just about the non-operating expense and revenue. That's where some of the investment income from our investments, reserve money that the hospital invests. A lot of the investments have been called, and so we're reinvesting, but at very, very low interest rates. So this negative variance of $55,000 for the month and $173,000 for the year, that is going to continue with the non-operating income due to what we are able to invest. But year to date, with our net income, we're just right at budget at this point. So on the P&L, all positives. On the balance sheet, those were also very positive trends. Our days in accounts receivable came down 12 days as we factored in a normal revenue number in our denominator as you calculate days in AR. And then we had a very, very good month with collections. Our days cash on hand increased by 8.5 days. So the payer mix on the graph continues to improve, and then we have also made some the movement of women's health and pediatrics over to the MAC and bringing them under the Medical Arts Center Rural Health Clinic umbrella is causing our more encounters, the Medicare and Medicaid encounters, to be paid at our RHC encounter rate, and that is significantly enhancing reimbursement for our clinic operations. So a very good report. Are there questions related to the month of July on the finances?
I just want to say how much I appreciate not having to follow Scott's finance reports in months like this. So that's a tough act to follow. So
yeah. Well, and I mean, this is the second month in a row that the clinics have shown that they've not lost money. And a variance of $200,000 is pretty significant. So you're going to keep that trend up, Scott? That's a pretty tough trend to follow.
He'll be seeing as many patients as he can.
Yeah, right.
That's right. It's a combination. There's a lot of things from a financial perspective that have aligned and are moving in a very good direction for us right now. So
yeah, and I mean that's basically the rural health clinic shift, right? Is that where most of that's coming from?
Yes.
Mm-hmm.
Carrie, can you chime in about some of the processes and volumes you're seeing in your clinic?
Yeah, I was just looking at yesterday. So we normally see on average about 350 patients a day. And yesterday, I think it was 368. So there's no signs of slowing down in August. A lot of that is our wellness visits. We need to catch up with that month that we, month and a half, that we had about a 60% hit with our volumes in the clinics. That is, a lot of that was our preventative care and our wellness visits. So we're booking out for those quite a bit. We were just looking at some schedules 2 days ago for women's health, and we're booking out till November for those wellness visits. But we're looking at those schedules of how can we how can we tweak those so we can get patients in so they don't keep falling behind every year. So anyway, they're just doing good work, and they're just happy to be seeing patients.
And that's a lot of patients, right? And the majority of those are going through the MAC now.
We have a lot of those going to the MAC, yes.
I had a quick question. I don't know if this is for you, Scott, or for Amanda Scott. Geez, I thought we had a lot of Mandys, but now we have 2 Scotts. Anyway, KV, so you say, you talk about the voluntary employee wage reductions. And you said, however, employees are still taking time off, which is reflected in the low productive FTE number. So is that, is this just normal taking time off, normal vacation stuff? Is it related to the COVID issue? What's the cause of that? I was just curious.
Yeah, great. Go ahead. Then I can respond.
I would say as you look at the productive versus the non-productive, there has been probably more non-productive time utilized than we typically would see. So it's higher than normal, and it may be some of it's COVID related. It's actually been difficult for people to get away at times, and so there is not any voluntary currently right now, but there is in the month of July, because that ended July 4th, the voluntary things that employees were doing. But we still have people that are taking time off, and that actually, because those expenses, where it's a cash impact, but it also is as you work into that PTO bank, it actually helps the wage expense portion of the calculation.
Yeah, and as far as the reason, what we're hearing from employees, because we do actually have a high amount of leaves right now that are non-COVID related, is that for the same reason that we had surgeries have low volume, now that surgeries and appointments are kind of back in progress, our same employees who had pending medical needs, they're now taking leave for their needs as well. So our employees are also our patients, and so we are finding non-COVID related leaves right now increasing. And of course, the normal, summer vacations, people aren't really traveling, far, but they are still taking time off. And I've also heard kind of some feedback from employees where they are trying to schedule in vacation time before the end of the year, just anticipating that, it might be a busy fall, and they don't want to lose any accrued hours that they have gained at the end of the year. So a mix of reasons as usual, but definitely high and not all COVID related.
Okay, thank you guys both. Thanks.
I'd like to just make a quick comment to Scott. I would like you to make sure that the account receivable individuals realize what a wonderful job they have to decrease our account receivable days by 12. That is a significant change. That's decreasing the days over 10%, and that's a lot of work. I know it is to constantly work on that to bring in those receivable dollars. Other institutions I've been at, that is a significant amount of work. So please let them know that at least me from the board, and I'm sure the rest of the board is very happy by the crazy work they've done to redo that.
Terry, it was a bit of a calculation benefit. The overall AR stayed about the same. I don't mean to minimize the excellent work that is occurring by them, but they did benefit this month just to a different denominator being used. You use a 3-month rolling average for your average revenue that so they benefited from that. But they're a little bit of, when we spiked up to 94 the prior month, it was not because they weren't doing good work then either. They continue to do excellent work, and we're gradually pulling that AR down.
Well, even though the books may have been cooked this month to make it look a little bit better, it's still wonderful that they're doing a great job. So thank you.
Thank you.
So can I draw your attention to a couple of numbers on page 33, the key statistics and indicators? I just want to point out that on line 28, as you look at our expenses per adjusted patient day, those are not only under budget, but they're 11% lower this year than they were last year. And then under revenue, or what our patients are experiencing in terms of charges and on their expense side, we're down about 9.7%. So my argument has always been that a well-utilized critical access hospital system is about as efficient a healthcare delivery system, because our costs are so fixed that when we get busier and when you add that additional volume, there's very little additional expense. And I think we see that playing out this year. So that's part of that value calculation for the public and the community.
Thank you.
Scott, I had a question. The write-offs for untimely billing, is that still left over from like 2018, the stuff that kind of fell by the wayside during the transition of accounting systems?
I don't know that I can answer precisely. There's always some untimely billing. When I was actually pleased when we ran the report this month that it was down considerably from where it was. I wasn't going to. I don't know that we're completely out of the woods with that yet, though, and so it may be. I don't know the answer exactly, John.
Okay, but I think we're trending downwards though as we clear off some of that old stuff that was sitting by the wayside.
This is the first month that we've had a downward trend. It's been fairly flat up above $100,000. If this continues for a few months, I'll feel a little bit better, but I don't know that I'm ready to say that we're completely out of the woods with that yet.
Terrific, thanks.
I would like to add a comment about grants this last month. Mitchell Rhodes was able to get approval for a $750,000 grant for the Kittitas County Health Network. That money will come in for over 3 years, so about $250,000 per year. And then they have a grant from Capture Care to do vaccinations for $25,000. So that those were two significant grants that the community will benefit from.
Very impressive.
Yeah, that's a lot. So the care coordination, is that someone, what is that actually going to do?
So a lot of that is money that the network is probably going to use in support and grow the care coordination work they have, which is principally what's been called the A-team. And it's been a while since the board really heard a presentation on that.
Yep.
But what that is a group with representation from KVH, KVFR, law enforcement, the university, CHCW, aging and long-term care, the assisted livings, Prestige, and basically we're trying to identify individuals who are failing in the community, falling through the safety net, and trying to support them as best possible, whether that means making interventions that allow them to stay where they are or getting them to a more appropriate level of care. And that's work that's been largely done with in-kind donations. And what the network is looking at is taking on a more formal case management role supported by MCOs that to try to get upstream so that instead of dealing with disasters, we're preventing problems.
That's awesome. I mean, that program was, we always wanted that program to kind of take off and to get that kind of acknowledgement, to really get it to the next level and to help folks that just need someone to follow up with them. It's a big deal. Yeah, that's huge. Congrats.
I would like to provide an update about Kaiser, where we're at with Kaiser. There was we sent the notice of intent to terminate the contract on the end of July. So that was sent to Kaiser and received. On August 14th, we sent notice to the Public Employees Benefit Board and the School Employees Benefit Board, advising them that KVH would not be a Kaiser provider effective July 31 of 2021, and that we were working with local employers and school districts to let them know of this change. And we have been reaching out to city, county, and school employers to let them know that KVH will be not a network provider for Kaiser. And then lastly, we have a letter that is going to be sent to all of the Kaiser patients that we have in our system, and to let them know that we will be not in network, and as they go through their open enrollment this fall, that they will, if they will need to, if they want to have services all of 2021 available at Kittitas County Healthcare, that they will need to select a plan other than Kaiser. And so this letter will go to patients and let them know of that. It also lets them know the name of 2 local insurance brokers for those individuals that buy their insurance through a broker, that Mitchell, Reed, and Schmitten and Virginia Gaken Insurance are available to help them select a different plan. So I think Michelle had said there's 1,941 letters that will be going to patients to let them know. And then we have a telephone number that we indicated in the letter that is will be dedicated to taking questions from patients that have Kaiser, that we can follow up with them and provide information to them for questions and concerns that they have. Tara Preciado or Becky Litke in Revenue Cycle will take the initial calls, and if there's other calls that they have, I will be fielding some of those calls. So I think Julie's indicated she's willing to call patients too. So any questions about where we're at with Kaiser?
That's a really good idea on money well spent on sending those folks letters. Give them.
I'll also just add, we posted the, I'm sorry, Bob. We posted the contents of that letter on our website under the billing section where it talks about insurance plans that we accept. And we've also made the notation on our website on the Kaiser plans that those will be valid through July of 2021.
Okay. Terry?
So at the Foundation board meeting this month, I did bring this up that we were going to be terminating our Kaiser contract. I thought they should hear it from somebody on the board before it came, because I know it was coming out. And there was an individual that owns his own business here in town, a small business, and he made a comment that there really wasn't any other insurance available with the Affordable Care Act other than Kaiser in the community. And I didn't really know where to look for that, but since you've been talking about the different insurance brokers and stuff, are there a lot of other plans that are available out here? Was he just maybe not sure about what he was looking at?
Yes, there are. There's Virginia Gaken. There's 3 plans that they currently offer. They offer Kaiser, they offer a plan with Ambetter, and they offer one with Primera LifeWise that are a plan. So there are alternatives.
Okay, because I did suggest that he talk to one of the insurance brokers in town just to see what they had, and then I did mention kind of what's in the letter and stuff like that, that Kaiser really is kind of pulling away from this area anyway, that their big focus is over on the west side where they actually have their facilities. So to get better local patient care, it would be better for him to move to another insurance plan. Whether we were losing, not billing him anymore, because a lot of people that had Kaiser had to be transported to the west side to a facility over there that was inside the Kaiser plan. And he said, I haven't been sick, so I guess I didn't realize that. And I said, well, then you just don't get sick, okay, until you get a new insurance plan, because I don't want you going over to the west side unless you want to. So he wasn't real upset. He was just concerned about being able to continue to supply insurance to his employees.
I did reach out to another one of the foundation board members who had some questions and was covered with Kaiser, and we talked about that. I think what this individual had said is, they remember the very positive experience that they had with group health, and she acknowledged that Kaiser, Kaiser is not what group health used to be. Things have changed.
Yeah, and Dr. Solberg actually brought that up in the meeting when this gentleman was talking about back when group health was here. In fact, the KVH was a group health, had used them for their insurance at one time. They were very in-network, and they really did support their in-network providers throughout the state. When they merged with Kaiser, it changed their whole focus, and they just really not are that supportive of their in-network providers that if they're not in the west side area over there. Okay, well, thank you.
Welcome.
Scott, I've got a question for you. At a prior board meeting, was it brought up that we could contact patients based on filtering the information through the system to find out who those patients are and then messaging them on the patient portal about that switch?
I don't know the answer to that. Michelle can.
Erica, that's a good question on whether they can do that portal wise, if they can filter it. And I will follow up with Jeff on that tomorrow and let you know.
Thanks.
Okay.
And Scott?
Yes.
It was my understanding, I thought the state passed a law that takes effect next January where the state itself was going to offer some sort of medical related insurance starting January 1st. Does anybody know if that is true and if that's going to happen?
That's true. That is the state, those plans, it's called Cascade Care. And we have chosen to participate with Cascade Care with two plans. One, Regents approached us, and they want to be in the Cascade Care market, which is kind of the exchange market. And then the other plan that we have agreed to a contract with Cascade Care is Community Health Plan of Washington. So we are going to participate with those two plans.
And do either of those two have relevance to what we're talking about? Additional options come enrollment time for next year?
They're not. They're more of what they call the exchange planned options, as opposed to this. Although there's some crossover, I believe, potential crossover.
Because the exchange is related to income, not just a private business. Is that correct?
That's correct.
Okay, thank you.
So is this similar to like Molina?
Cascade Care?
Yeah.
Not really. Molina is a managed Medicaid plan for the most part, and they do have some Medicare. But Cascade Care is an initiative that Governor Inslee and the Healthcare Authority wanted to establish, and it seemed, when we have communicated with the plans, it seems to be kind of a replacement for some of these exchange plans. That's the market that Regents indicated that's the patient population they're looking at, and same with the Community Health Plan of Washington.
Yeah, I mean, that's, thanks for bringing that up, John, because that was news to me.
I think we're one of the first states where the government at the state level is getting behind this for more than just children. I don't know if that's accurate, but that was the sense I got when I read through the law proposal.
Does the board want to get a little bit more information on that? I mean,
I would welcome it. I'd like to understand more of what's coming 4 months from now.
yeah.
I'll get.
That'll be good.
I'll try to provide some additional information.
Okay. Thank you.
I'll just point out that the Hospital Association has a couple of position papers on this out there. So they have some very strong opinions on it, and they've been very active with it. So I'm sure that Wish will help us pull together some information for the board, Scott.
Okay, thank you. The other piece of information I would like to bring up to you all is that we due to a finding that came up with the Washington state auditors related to how we procure architectural and engineering services, they pointed out that we had not gone through an RFP process or RFQ process for doing these services. And so to comply with that, we did an RFQ seeking a statement of qualifications from various architects that to provide architectural engineering services for Hospital District 1 and Hospital District 2. And these were published in the Daily Record and North Kittitas County Tribune on June 18th and June 25th, and with a request that they submit a RFQ or statement of qualifications by July 15th. We received proposals or presentations from 13 different architecture firms, some in Seattle, some in Portland and Oregon, in Yakima, and we evaluated all of the 13 proposals. Randy Kaiser and Ron Erlacher and I went through the proposals, and we came up with a recommendation that we all came to the same conclusion that our number 1, 2, and 3 were all the same. And the conclusion was that KDA Architecture of Yakima was the preferred architecture firm that we would want to continue using. So I have a request that the board approve an action to approve KDA Architecture of Yakima, Washington as the architect of record / on-call architect for Kittitas County Public Hospital District 1 in accordance with RCW 39-80.
So I would move to approve that.
We have a motion by John, a second by Matt, to approve KDA Architecture as the architect of record, according to RCW 3980. All in favor?
Aye.
Aye. Aye. Any opposed? No opposed. Great, thank you.
And the last item that we had that was discussed at the Finance Committee was there was a resolution, a advance funding resolution that is in the packet that the Finance Committee wanted to not take action on this month. And an advance funding resolution is an opportunity. It gives the district the ability to borrow tax-free dollars to repay ourselves for capital expenditures that the hospital may incur for over the next 18 months. And this is the amount in the resolution that was $6 million, but there was discussion. We didn't have a firm amount about whether that was the 6 million was the correct amount, or it should be higher, should be less. So this was, but it's something that we will bring back to the board next month for some additional discussion. But that I think Bob and John felt like this was premature to be taking action on this at this time.
Yeah, I would just like to add, we had a really interesting educational presentation during the finance meeting to talk about how these bonds work. And it certainly left me feeling like I wanted to do a little bit more research and not rush a decision. And I wanted to have a chance to talk to the other board members over the next few weeks to kind of brainstorm what is best long-term for the hospital rather than just immediately doing this. So it was kind of my desire to not rush into it, and then Bob and Scott, everybody seemed very comfortable with it. And if something was to present itself where we needed to move quickly on this bond situation, we could call a special meeting if need be to authorize it. But it didn't feel like there was anything urgent that necessitated that. So that's why I'd kind of encourage us to just take a few weeks to explore some more nuances of this opportunity.
Yeah, I agree. And we were looking at cost efficiencies also. So they're gonna come back and bring some different numbers and see where those cost efficiencies are. So yeah. Any questions for Scott on that? Great. Thank you.
I don't have anything else unless if there's no questions, then thank you.
Thanks, Scott.
We'll move to operations report first with Vicki, Chief Nursing Officer.
Vicki's not in, but I would be happy to take the questions and then pretend like I don't know how to unmute myself on Zoom. Only basically to tell you I won't be able to offer too much in just reviewing her report. She's definitely been busy and taking this well-needed time off for sure.
Yeah, with all the work that everyone did with the ACF, which was truly amazing. Time well taken off. So any questions for Carrie on behalf of Vicki?
No, I think Vicki's report is very thorough as written. So
yeah. So we'll go to Chief Ancillary Officer Rhonda.
Hi. Well, as you can see, we've been very, very busy, I think, in all of my departments. So I have just kind of a few updates. I wanted to recognize Colin Niebeck in lab. We did have some issues with our CHCW interface going back and forth with our fax for getting their lab results, and he was just really instrumental in working with them and working with Dr. Powers and our IT department to make sure that that got corrected and that the providers were getting their results. So I do want to thank Colin for that. And then I wanted to also update the board about Hospice Friends. Their executive director, Ken Grannon, has resigned. He's going to be working as a coordinator for the airport, which is a really exciting opportunity for him. And we're very sorry to lose him as the executive director because he's done an amazing job in the time that he has served there. So I know the board will be looking for another executive director, and if you know anyone, please encourage them to apply for that position because they are a really important partner for us. And then I would also want to recognize the work that pharmacy has done with the alternative care facility as well. We did scramble on one Saturday to do a bunch of hospice admissions on Saturday and Sunday, and our pharmacy then filled comfort packs for those hospice patients. And then when we converted this over to the ACF, they had to then fill all the residents' prescriptions very quickly. So they had to really go outside of what they do in their normal day-to-day. And it was really a fabulous example of us having a retail pharmacy and the advantage that that provides to our community. So it was a lot of work. Our staff that worked there loved working there, and we're excited to work there and take care of the residents. And then also the agency nurses, when I spoke with them, they're like, this is the best place. You have to keep it open. We want to come back. So really happy that people enjoyed working there. It wasn't a burden at all. It's something that we all truly enjoyed and felt good about giving back to our community. Do you have any questions?
I have a question for you, Rhonda.
Yes.
It says that it looks like flu vaccine will be difficult to come by this year. Can you please elaborate on that? That sounds really concerning, especially this.
It is concerning. I know probably by September, October, we're only going to be getting probably 250 doses. And I think that they will really be rationing that out to us, not giving us our full orders. And it's always very frustrating that the pharmaceutical companies provide flu vaccine to retail pharmacies ahead of hospitals. And, you know, I wish that there was something that we could do to change that, but we're sort of out of the decision-making process on that. They sort of do what they want to do. And you know, many years we've had flu vaccine shortages. I'm sure Terry can share what that's like from a pharmacy director perspective and how often it's happened in the past. And we always have to then put in place sort of an allocation process. Who is going to get vaccinated first? Is it our frontline workers? Is it our physicians and our nurses? Is it our frail elderly patients? Is it our children or pregnant moms? How do we go about vaccinating our own staff?
Would you suggest that those who are able get a vaccine through the pharmacy rather than through the hospital then, since the pharmacy seems to get the lion's share up front?
I would say that's a personal decision as to where you wanted to receive it and when it's available. I know a lot of people don't like to take it too early in the season because people feel like maybe some of your protection wears off. But if you feel like you can wait until a little bit later, our supply might be more stable at the hospital.
You know, speaking about historical, the big thing is we would always get our flu vaccine through our buying group. That would be where they would help us get it. And compared to the vaccines that the hospitals would buy in Washington State, it's such a small number compared to what the retail stores purchase. I mean, it's just a huge amount that the retail stores purchase compared to us, and so it ends up impacting the supply and demand on what it is. So with our, I was just curious, with our healthcare plan, if somebody did want to get a flu vaccine out of the hospital, it would be covered here. Would they be covered at the hospital, but then if they got it at a retail store, would they have a copay?
I don't know the answer to that question on a copay at a retail pharmacy.
Okay.
Anything I've gotten done has been covered. I'll just say that. I don't know what everyone else's insurance is.
Yeah, so I just, you know, because I know, you know, if they're covered by Medicare or something like that, that, you know, Medicare pays for those flu shots wherever they are. But I would like to see that, make sure that our employees, if they want to get a flu shot, I know the flu vaccines is starting to ship. You know, I still work for Weimar, and they received their about 25% of their initial shipment about a week and a half ago. I was down at one of their stores in Oregon, and they've already started vaccinating people. I believe that's a tad too much. It's not according to the CDC guidelines. I was giving the vice president of Weimar at a bad time about not going along with the CDC guidelines. Although he did say the one thing that the CDC says, the best time to immunize somebody is when they're standing in front of you. But anyway, so the vaccines are starting to go in. I don't know if Dr. Martin has any comment about that or not, about when to vaccinate people.
Well, it's been a source of frustration for over 11 years that, I mean, when we had the 2009 H1N1, my practice received 50% of our allocation in May. And we just sent it back. The idea that the supply chain through retail pharmacy is more reliable than through a physician's office or a hospital system it chafes. That said, from an individual standpoint, I think the CDC guidance, the best time to give a vaccination is when the patient is standing in front of you. I would turn that around and say the best time to get vaccinated is when you can.
And that's a good time to get vaccinated. So I appreciate Dr. Martin. I know the vaccine has been, it's been just horrible. You know, working with other pharmacy directors when I was pharmacy director at KVH, that was probably the one thing that just drove the pharmacy directors insane, was trying to get the vaccine, trying to get it allocated, and it was always crazy because, you know, like what happened to your practice, that happened to us before, yeah, at the hospital one time too. We didn't get our vaccine, and then all of a sudden we get this big shipment just before the vaccine expired, because the vaccines all expire in June of the next year, and it's like, no, we're not taking this, take it back. So
The other thing I'll say is that I gave a 1-point lesson in huddles yesterday that was in November, if the forecasts are accurate, we expect to have 2 major viral outbreaks circulating, and we have a vaccine for one of the 2 viruses, so by all means get the damn shot.
Is there any word on the accuracy of this year's flu vaccine? How well it matches the virus?
We won't know until we start seeing outbreaks. It's the retrospectoscope is the most abused instrument in medicine, but that's the only one that'll tell us how good the vaccine was.
Do you know what the match was for 2019, 2020?
I want to say that they were saying that it reduced transmission on the order of 60%. So reasonable, always, never perfect. But we didn't have well, actually, truth be told, we were in the early stages of an influenza A outbreak in February. And when we were doing early testing in the COVID clinic, if we did biofires, in addition to the coronavirus, there were 6 other respiratory pathogens circulating, including influenza A. And I think a lot of what we've done to address the coronavirus pandemic blunted or completely headed off what could have been a pretty impressive influenza A outbreak. So the fact that we didn't have that outbreak in February and March just says that hand washing and social distancing and covering your cough, all that stuff actually works. And we saw it. The most recent round of biofire testing that I've seen, if there is anything still circulating in addition to coronavirus, all I've seen is rhinovirus. All of the other, there were 2 other coronaviruses. There was RSV, there was human metapneumovirus, influenza A, and rhinovirus circulating in February. And all of those have been extinguished except rhinovirus and coronavirus.
I thought we had a influenza A too, like in June or something, which we thought, I wonder if that's happening normally and we're just not doing that many respiratory biofires in the summer. Anyway, I thought I had heard of another influenza this summer.
It didn't cross my desk, but when you say that, I think I heard about the family, but it wasn't a test that was done in our clinic.
One more question for Rhonda. So other than like the amazing senior leadership, how many staff members did we have working at ACF?
I believe we had 4 frontline staff working there.
Okay.
So they were a tremendous help.
Yeah. Is there any way of like acknowledging them somehow, or I mean that?
Yes, well, Julie provided some gift cards to them
Okay.
personally. And then at admin team, we all signed a thank you card and gave them another gift certificate as well. If you wanted to do anything more, I would leave that up to the board.
Yeah. No, I'm just glad that they were acknowledged, because that's, you know, I mean, everyone involved there is taking on a lot of risk, and
Yeah.
so
When I took Haley Ellis, her card Tuesday after admin team, her comment to me was, I really miss them. I hope I get to see them again.
Oh, really? Yeah.
So I think we feel like we would like to have a visit if we're ever allowed back in just to visit.
Yeah. Yeah.
We'll also add, this is Manda, that we did work with both of the labor unions who the staff were represented from to kind of make sure that they were safe and felt acknowledged. And we did end up providing some incentive for them, kind of similar to float pay, but of course we didn't have all that mapped out in the contract to match this situation. So we also worked through their employment agreements to make sure that it was a fair and reasonable agreement as well. Yeah.
Yep. That's awesome.
Can I just mention the facilities folks that then were called by Prestige to go over, and IT was involved as well. They went over and helped get residents of Prestige back into the appropriate rooms and moved furniture and helped out, because again, that staff was already stressed and had their hands full. So they dropped everything over here and went over and helped with Prestige. So it was a great community effort, and I just can't say enough about Team KVH.
For sure. Thank you.
Yeah, I mean, John said a lot of this when Dr. Martin was talking earlier, but Rhonda, it really seems like you and Vicki and Dr. Martin did a great job with this, and you know, we really appreciate that. And I know Julie has told us that she appreciates all the work that you three did. I'm sure she said it to you, but she's sort of singing your praises. So good job on that. And I also appreciate, in a more minor thing, I appreciate how much detail you put into your report. That was very educational. So thanks for doing that too.
Thank you.
Yeah. Any other questions for Rhonda? Great. Thank you. So Carrie Barr, Chief of Clinical Operations, and I guess you're coming up with new words. Are you making augmetics up?
I know it does sound like it sounds like a medication. So that's how I had to start out my report. This is not a medication, but yeah, this is the scribe service. So we're not walking away from wanting to provide scribe service to our physicians and our providers, but this is hopefully a way that we will be able to sustain it. So our turnover rate for our scribes is just it's really high, and so this is again just something we've signed the contract. We're in the beginning stages, and we're getting ready for a kickoff next week.
So explain what they do. I mean, is it?
So
are they there physically? Are they there?
No, so the provider themselves. So if Dr. Martin would be part of this scribe service, he would have just his like regular cell phone that he would have that then mounts into the room. The camera is activated, and thank you, Dr. Martin, for being the Vanna. So they will be able to listen. This cell phone is only for augmetics. There's no other apps. There's no other function of that phone. And then the scribe is hearing and seeing what is needed. And then after they're done with the patient, then the provider can speak directly to the scribe and say, oh, by the way, add blah, 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 blah to that documentation of the patient I just saw, or even the patient I just saw at 9 o'clock, even though it's 2 p.m. And so they're in and out of the provider's charts all day long and communicating with the provider all day long. So it's as if they had someone physically there, but it removes the additional space or additional body in the exam rooms, which particularly at this time with just exposure, that is another plus. And there is an option to wear Google Glasses, but we thought we would start with the more simpler model to begin with. The Google Glasses would actually have something that would come through and say, don't forget to remind them about their mammograms. And that's just a little creepy. So we wanted to let's start simple and see if we get to that creepy point.
So, and is this for how many?
So we're starting with just a small volume to begin with. This is at Family Medicine Ellensburg. They're the ones that raised their hands and with most eager, as they do, being most eager. And we have 8 providers who have signed up for this service. This will not replace, we do have 2 scribes that are working in Family Medicine Ellensburg. So this will not replace or supplement any of their work. It is particularly for providers who did not have scribes.
Yeah.
Like Dr. Martin, poor Dr. Martin has always gotten just the, maybe what's left over, and most of the time that's not a lot. So he's on his own.
But that, I mean, it's fairly intriguing because that adding a person to the exam room does change the dynamics a little bit. And so this is intriguing for sure. So
yeah, and then this is a quick turn off the camera because you're doing a sensitive exam rather than that awkward, okay, I'm going to ask somebody to leave and we're going to do this sensitive exam, and then that person doesn't know when to come back to start scribing again. Instead they can just click it back on. And
yeah awesome.
So
I'd just like to point out that we had an opportunity, and we being Carrie, and I don't know who else went over, but this is a contract that was piloted by the Washington Rural Health Collaborative, that group of critical access public hospitals that we're part of. So this is a contract that Summit Pacific, I think, over in Elma, Washington had. So it's great to not have to kind of bounce around out in the market trying to find your own product. So we use the collaborative connections this time on it.
Great.
I've been a patient a number of times with various providers with remote scribing, and it was a little different at first, but I took to it really quickly, and it was really slick. It was seamless. And as you said, it's no awkwardness of an extra person in the room, which I've never minded, but sometimes space is tight. And as you were saying, during COVID, the fewer contacts we can be making, the better. So this is exciting.
I would just add that one of the things that Summit Pacific experienced is the documentation improved, so that the value of the RVUs for the visit improved, and that also improved the efficiency of the providers. So obviously there's some costs associated with the scribe and Augmetics, but it's actually, it ends up being a net overall savings or gain to the organization by doing it.
Yeah, and actually the overall cost is, I think it's 1 penny. When we calculated it, it was 1 penny higher per hour for doing the scribe service versus what we would be paying an FTE with benefits. So, and then as to what Scott said, the increase of the coding, and then they also will submit pending orders, and just the continuity of having a scribe. There are many times if a scribe calls out, well, there's nobody to backfill that space. So having that service, you then have, you don't have that lower productive day because there wasn't a scribe available. So yeah, it's very exciting. I'll keep you all posted and as we move forward.
Yeah.
Any other questions about Augmetics? I do note that there is the neurologist report out that I have in my, or notes in my report out. And the only thing I didn't mention in that I'd like to add is that this will be part of the internal medicine rural health clinic. And so that, that then provides just a nice incubator space for a new line of service, a higher Medicare and Medicaid reimbursement for that. So, so that's great. And we've been meeting weekly, a multidisciplinary team, as it states. We meet weekly, and we're making some great progress on being ready for opening day on October 19th.
Michelle, can you remind me what the rollout plan for him is? Michelle, are you there?
Yeah, I'm here. Sorry, it just took me a while to get unmuted with everything. Yeah, so we were talking about that today. I've got basically it's kind of like a preliminary fact sheet that I sent out to him about a week ago so we could understand the services. And then from there, we'll develop the traditional marketing materials, and then we coordinate with Mitch to make sure that he has what he needs to go around to all of the different clinics. So that we're waiting for his feedback on that, and we're waiting for a phone number, which we talked about today. And then I am hoping within the second full week of, or actually the first full week of September, that we can start pushing some of that out.
I'd be curious, what's the typical patient we expect to visit this neurologist? What type of neurology concerns are most prevalent in this community?
Dr. Gustafson has a strong background in behavioral neurology, so the dementias, also has a strong background in vestibular disorders, balance, and additionally we have, Washington has probably the highest incidence of multiple sclerosis of any state in the union. And right now, those patients in our community are getting their care most commonly in Issaquah, at Swedish Neurosciences or Virginia Mason Neurosciences. And those are pretty common conditions that people are going a long way to get care for.
Terrific, thank you.
I have a question about telehealth. I'm not sure if this is for you, Carrie, or if it's for Rhonda. I have a friend who had a telehealth visit. It was not through KVH, but they had labs that were ordered, and the labs, the list were all LabCorp providers, of which KVH wasn't one, and they wanted to be able to go to KVH because it's close, but the nearest LabCorp on the providers list that popped up, I guess, was Yakima. Is that something that we should be looking into, why we're not popping up as a lab provider for that? This was actually a couple months ago, and it just dawned on me when I saw the telehealth bullet earlier. So I'm wondering, is that something that should be available through various telehealth, or can anybody take a LabCorp even if they're supposed to go to Yakima and come to KVH for it?
Well, I guess I'm a little confused because some providers' offices will contract directly with LabCorp, and CHCW, for instance, just did that, and now they're switching to Interpath. So I don't know what type of a relationship they had there. Yeah, so I would need to know more.
Erica, some insurance companies also specifically require that patients go to a LabCorp or Interpath or something like that. And so that she may have, depending on her health plan, it may have been a requirement that she seek care or lab services from LabCorp as opposed to KVH.
I see. So perhaps when the patient is paired with the provider, then that populates any potential downstream interventions, providers for interventions after that?
Well, usually they have, they want those results interfaced, so they want you to use the lab that you're going to be interfaced with. So just like CHCW, they want their results flowing into their medical record, which is why we lost that account, because we couldn't get that bidirectional interface going. So they went with LabCorp for that reason.
I will have to ask her who the provider was. But it was a national, like I don't even know what they're called, but a teledoc, a telemed, something like that. So I'm not sure if there are certain questions that I could ask that would help determine what maybe happened, or maybe it was just a one-off fluke. I'm not sure.
Well, to Rhonda's point, you always want, as a provider, I want my people to go someplace where the result's going to come back to me directly. That being said, I have no control of that, and they can go wherever they want. And the only people that can really steer traffic that way are payers. And I suspect that it wasn't a decision she made when she decided on telehealth, but more probably a decision she made in open enrollment.
Any other questions?
Hey, Carrie Barr, you got green light today to push scheduled surgeries out. Is that, you've been holding them to 2 weeks, right?
We have been holding inpatient or any surgeries for 2 weeks scheduling, and the reason is just to kind of keep our eye on the temperature of what's happening with COVID. I chatted, or Amy Krogstad and I agreed that a 4-week would probably be a better time frame, and we're just waiting for Vicki Machuro to come back just to get her stamp of approval. I'm sure we'll state our case, and we should be good to go by next week to be able to do that.
Yeah, that seems like that's going to be critical around the holidays when people are going to want to schedule their surgeries to coincide with time off.
Yeah, absolutely.
Thank you, Carrie.
Thank you.
Community relations, Michelle?
Yeah, I'm here. Really, the only thing I want to add is it's been really nice to get my team back. They're doing a lot of what feels like catch-up work with the departments and the clinics who are updating their forms and updating information online and putting together new patient materials. And it's been really nice to do things outside of COVID. So other than that, I would be happy to take any questions.
I love this. This is great. I love seeing these charts. They're fantastic information.
Good.
When are the kiddo masks coming in?
End of next week. That'll be a fun distribution. All right, thank you.
Great. Thanks, Michelle. Thanks for your report. Education and board reports. Do we have anything to report there? And then on to old business. Anything to bring back? On new business, we do have the November, December meeting dates. The board can decide on if we want to push the regular board meeting to a different date. I think in the past we've kind of pushed Thanksgiving to December and then December to January. Is that right, Mandy Weed?
I already have them on my calendar as pushed out. Did we not? Sorry, Mandy.
I don't think we set any official dates.
Oh, I guess I was just assuming then.
So does anybody have an opinion or objection to pushing those?
If you look
November
at
to December 3rd.
If you look at October, we're on the 22nd. And then November, if we went a week before Thanksgiving, we'd be on the 19th, which is almost a full month. I hate to get too far between these meetings. I kind of felt that coming in at the start of my term where, my first meeting in December was actually a November meeting, and then we didn't have a meeting again until January. So I don't know, at least for the November one, I would think the 19th would give us 4 weeks in between, and rather than going 6 or 7 weeks in between. That's just my initial thought.
Does that get the?
Yeah. Sorry, go ahead.
Go
Bob.
ahead. No, go ahead.
Yeah, I mean, the problem, of course, is then what to do about December. Because if we push that into January, it would be a huge gap between November and December.
And I'm going to jump in for finance here. The 19th is our early date to turn around all the financial data that we'll need for October. And that's also when we're doing the budget. So they try to get as much work done as possible so they have a good update for the board on the budget.
Yeah.
So it sounds like people are not gravitating to my suggestion of the 19th is what I'm hearing.
I mean, I could do the 19th. I'm just worried about having something November 19th and then nothing else till January, 3rd or whatever.
And we're opposed to Thanksgiving Day meetings? Is that what's at issue here?
Gobble, gobble, gobble.
I'll do it by Zoom with a
Gobble.
turkey leg in my mouth. All right.
I wouldn't mind seeing the meeting on the 19th. Would that, would be then pushed the meeting earlier in December? I kind of had the same feeling with John when I was, I got elected, but my meetings really didn't start. And I thought it was kind of weird having the December meeting the 1st of January. And then right after that, it wasn't that far away, we had the January meeting. I know it's tough trying to get around the holidays.
So that's the tricky part. I mean, in addition to the finance issues that Julie raised, if we did, I don't have any problem moving it up in November, but what do we do about December then? If we move that up, then we're running into the same problem. We've got 6 weeks or whatever between December and January, which maybe isn't a problem. But
Well, then in November, December, you'd probably have 2 months where you wouldn't have complete financials.
yeah, that's
Get into the early month, the financials were, it's a push to get everything.
Can I suggest something radical in that we maybe don't do it on a Thursday?
Right. I was just going to say, you don't have to move it a full week if you'd like to move it to the following Monday or something.
Looking at Thanksgiving week, perhaps there's Monday, Tuesday, the 23rd or 24th, or any date surrounding that might be a potential candidate.
Yeah, I'd be very open to the 23rd or the 24th.
What about the 30th? Go on the 30th, and then that gets us. It's December that really throws.
So there's nothing, as far as we know. I mean, I know there's nothing in state law, but is there anything in our bylaws or anything that says we got to have it at a certain time?
Nope.
Okay.
It will, by definition, be a special meeting.
All right.
It would have been anyhow, though, right? Since we
Yep. If it's not on the fourth Thursday, it's a special meeting.
So in November, I'm okay with either days, 23rd, 24th, or the 30th, whatever the board wants. December gets a little trickier.
Yeah, that's fine for me. I just don't know what to do about December.
Would it be easy on Scott if we had it on that Monday?
Are you Monday the 30th or the 23rd?
The 23rd.
We could probably make it work.
Would the 24th be any significantly better or marginally better?
Not really.
So
I like 30th better than 23rd.
Yeah, in that scenario, when are you anticipating finance committee being held? If it's because it's
we probably wouldn't have finance committee if it's on either the 23rd or 30th.
And just working backwards, I would propose the 22nd maybe in December. Or is that too close to the Christmas break for people?
Yeah, that's pushing it. I mean, if it's Zoom, it's not a problem, right? Because you can do that from anywhere. But I don't know I mean, I don't know where you
We'll
were
be
all.
missing folks that week of Christmas, and then the week of Thanksgiving. People are going to take off. I mean, I plan on being here, but I just think we're.
Well, I mean, I would defer to, Bob and Matt and Erica. They've, had a few years where they've had to juggle this time period, and I'm sure this has in some ways come up a little bit before. So I think strategically, whatever the three of you think is smartest, I'll get behind.
Yes, so should we do like November 30th? Does that work for?
That's fine for me.
Works for me.
Yeah, fine with me.
Yeah, I'm sure I can work that out too also.
Okay. And Julie?
Yeah, I'm more concerned about December. So if you'll recall the way we've been handling the budget, you receive the budget then on November 30th and are invited to meet with Scott. But they are working that budget by design right up to the very last minute in December. So any changes that we have, any new recruits, that we have coming on board, they're refining that right up to the last minute. So if you move that December meeting up too much, it's going to push the budget process. So, Scott, any other input?
I think we've typically approved the budget in January, correct?
At the December meeting in January.
Yeah, but the December meeting in January is going to be, December we hold open longer. So if it's.
I don't understand what you're saying, Scott.
I guess I was saying, if we were meeting on the 22nd of December, we'd be reporting on November financials and probably a first pass at the budget then? Or would that be on the 30th of November?
No, at the December meeting, you should be approving the budget for the following operating year.
So how about the November meeting on November 30th and the December meeting on January 5th, which would give us 2.5 weeks, or it's almost 3 weeks before the official board meeting.
Is later in December not a particularly good idea, say the 28th or 29th, or is there concern that people will be out of town?
People will be out of town.
But also sounded like with the budget, they needed like every day they could get. Am I right? Did I hear that right?
Correct.
That's what I was saying. I'm not sure that's what Scott's saying.
No, we do need every day we can get on the budget. Absolutely.
So let's.
Oh, I see. I was thinking that it would have been done by the 4th week in December, but since Christmas, we don't meet then, but never mind. Go ahead.
Sounds like we should push into January then. I mean, I don't have a problem with the 5th. I mean, my inclination, I guess, would be to go with a Thursday since that's what people are used to. But I mean, I'm free the 5th, the 7th, whatever you guys want to do.
The 5th is a few days sooner, so it seems kind of maybe silly to move it off of a Thursday for a 2-day benefit.
Yeah. Terry, John?
I mean, I can do that. It also gives us a time so that we can do an agenda review with Julie.
You're saying the 7th of January?
Yeah, the 5th or the 7th. I mean, I guess that would be. What about you, John?
Yeah, I mean, instinctually, I like the 5th, but I understand the argument to keep it on the Thursday. Since it's a special meeting, I'm not opposed to it being on a different day. If it just closes out the 2020 year and gets us the budget for 2021.
So would January 6th be the compromise because it's in between the 5th and the 7th?
And maybe would leave a little bit of that up to Scott, which of those days that, although I have a feeling he'll take every day that he's given, so he might prefer the 7th, just so they feel a little less frantic.
I like the 7th.
I'm with Erica. I like the consistency on Thursday, so. But.
Okay, January 7th. Okay, I'll sign off on that.
Okay.
Oh, what?
All right, so the board's in agreement. November 30th, we'll have a special meeting, and January 7th.
Can we get this in the form of a motion to officially set?
Okay, so a motion to move dates to a special meeting in November and January, November 30th and January 7th.
Yeah, I'll make the motion. I'll move that.
Motion by Matt.
Second.
Second by Erica. All in favor?
Aye.
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 No opposed? Great. Anything else before we take a short break? Well, we're going to have executive session. How long do you think executive session will last, Julie?
I believe executive session will last about half an hour with no action.
Okay. And this is by phone again.
Correct. So just call into the number that Mandy has provided. She emailed that.
Okay.
Come back here to close the meeting, right?
What we have been doing is, unless there is action anticipated, we go ahead and close out the video, and the minutes reflect so the written minutes will reflect that we adjourned executive session, went into public session, and immediately adjourned.
So we don't need to stay logged in here?
No, since I will not be asking for action.
Okay, thank you.
Okay, so take 4 minutes to take a break. We'll reconvene at 7.
No, that's good, Bob. That's
okay.
Good.
Thanks so much,
Thanks,
everybody.
Thanks, everybody.
Thank you.
Thanks, everybody. Have a good night.